Dr. Jack West, and I'm happy to talk today about the topic of immunotherapy for patients with a lung cancer that harbors what is called a driver mutation, a specific mutation in the cancer that we have identified and can treat with a targeted therapy, usually in a pill form that is often very effective. And this is something that we want to do at the initial workup of a patient with at least more advanced lung cancer to find one of these driver mutations and know whether we have a pill-based therapy or occasionally some other kind of therapy that can be very effective for it. It's important to identify this both so that we can figure out the best treatment up front for a patient or when to sequence a targeted therapy, and also because the option of immunotherapy, either given alone or combined with chemotherapy, has tended to be far more effective for the patients with a lung cancer that does not harbor one of these driver mutations. Specifically, the most commonly identified ones, at least historically, have been targets called EGFR, or epidermal growth factor receptor, and ALK for anaplastic lymphoma kinase. And there's a few others, but these cancers have, in the limited extent that they've been studied in patients who have gotten immunotherapy, don't seem to have a good effect, at least not nearly as commonly as immunotherapy works well for patients with a cancer that doesn't have a driver mutation. Because of this, in many of the trials of immunotherapy or chemo with immunotherapy, patients with an identified EGFR mutation or ALK rearrangement are not included in these trials. So what can we say? Well, one thing is that for patients with a driver mutation, usually immunotherapy alone or with chemo is not going to be the optimal first-line treatment. And instead, we're going to prioritize the targeted therapy against that driver mutation. One important thing to bear in mind that we have learned in the last few years is that not all driver mutations are the same, and we shouldn't lump them all together. We know that patients, as I said, with an EGFR mutation or ALK rearrangement are much more likely to get a great response from targeted therapy than immunotherapy or chemotherapy. And this is important and true even if their cancer has high levels of a protein called PD-L1 that is usually associated with a better response to immunotherapy. So in patients with a driver mutation, the PD-L1 testing does not have the same predictive utility. And even if it's quite high, it just doesn't mean the same thing and can be a fake out. What's also important is that patients with certain mutations like KRAS, which is really quite common and has a relatively newer targeted therapy associated to treat it, these patients can respond very well to immunotherapy, as can patients with a mutation called BRAF V600E, which is relatively uncommon but can be found. So these patients can be treated with chemo and immunotherapy just like other patients. So not all driver mutations are the same, but for most of them, we will be inclined to give immunotherapy later on as a second, third, fourth line therapy, if at all. Right now, there are studies ongoing that are looking at whether adding immunotherapy to chemotherapy for patients who have already been on and had progression on, say, an EGFR inhibitor therapy adds benefit. And we still need to clarify whether there is a benefit to adding immunotherapy to chemotherapy for these patients. But right now, it's really more a matter of judgment. So those are the key points to say that immunotherapy for patients with a driver mutation in their tumor is something that usually means that immunotherapy is going to be a later consideration, if at all. We are learning more about whether it helps as a second or third line therapy. And for most of these driver mutations, the highest priority is going to be a targeted therapy first, but it is important to note that not all of these driver mutations are the same, and that ones like KRAS and BRAF are usually treated as for patients who don't have a driver mutation at all, with first-line treatment being chemo and immunotherapy. We have a lot more to learn about this, and we'll keep updating as we get more data.